Dear Professor Skolznicki, dear Secretary of State, Dr. Lander, he is already busy. He went to work, went back to work. Dear Arthur, it's a pleasure to be here, and all who are living here in Krakow very privileged because I enjoyed your city today, and it's amazing. The style of the city, the charm, the atmosphere, so it's really a pleasure to be here. And it's a pleasure to be here to share with you some data about myeloma. I'm sorry that I'm speaking before starting talks about active treatment, but I'm going to talk about supportive care, and Arthur asked me also to talk about maintenance therapy. So I will start with supportive care, as you will see here. And of course, there are many issues in supportive care which are of utmost importance, but due to time constraints, I will only focus on few of them. But I think infections are one of the most important side effects of therapy, but they are also associated with the disease. They are due to the immune suppression of the disease. And what is important is that about 20% of deaths which occur in myeloma patients within the first 2 months after start of therapy are due to infections. And when you follow your patients for all the time, their time course, you will find out that 20% of the deaths during each year are more or less due to infections complications. So infections are very important, and of course we need to do our utmost to prevent these infections as far as possible. And when you look at the nature of infections which play a role, you see that in the beginning the majority of infections are due to bacteria, but then with starting therapy and with more suppression, immune suppression of the T cell system, you see that viral infections come up, and fungal infections play a minor role only in transplant patients or with high-dose dexamethasone. You're well aware of that. So what are the risk factors? There are patient-related risk factors as shown here: age, multimorbidity, immobilization, but more importantly, the disease-related risk factors. Active disease is an important factor which, of course, enhances the risk for infections complications. Immunosuppression by the disease. Patients with renal impairment have a higher risk. Actually, they have the highest risk for dying of infection complications. Relapse disease is another important risk factor. And, of course, our disease, which we administer to our patients, particularly corticosteroids, high-dose melphalan, and proteasome inhibitors, they all pose our patients at increased risk for these problems. Just see which. So what can we do, and what is the present recommendation for prevention of infections? I just check where I should. Yeah. So when you deal with your patients and when you see your patient in the outpatient clinic, of course you have to offer, or you should offer, preventive measures, particularly vaccination. Influenza, patients should be vaccinated, but not only the patients, but also the contact persons and the caregivers. You should vaccinate against Haemophilus influenza, against pneumococci, hepatitis. Varicella zoster, there is a vaccine which is presently in a clinical trial. The problem with this herpes zoster vaccine, it's a live vaccine, and presently most people believe that we should avoid live vaccines, but I don't think that this vaccine will be a threat to our patients, so you may consider that. But there's a problem with all these recommendations because they are eminence-based. There is not enough scientific data available to support the usefulness of these activities, and you are well aware that patients with myeloma have a poor response to vaccines, and you should revaccinate your patients. And there's a CDC, Center of Disease Control, recommendation for myeloma patients. When you use pneumococci vaccines, you should start with a 13-valent vaccine and then move on with the 23-valent vaccine. So that is vaccination. And of course, prophylactic therapy is a must in patients who are on proteasome inhibitors. And you may consider antibacterial prophylaxis in selected patients, not in everybody, in selected patients with multiple myeloma. So when to use antibiotic prophylaxis? In elderly patients, in patients who come in with a history of frequent episodes of infections, in patients who have a particular risk for febrile neutropenia. And of course, these are patients usually with poorly controlled myeloma, which have this increased risk. Elderly patients with poorly controlled myeloma with comorbidities. Which prophylaxis is recommended? Fluoroquinolones, but you may have heard about that. Now there are certain warnings against use of fluoroquinolones because of neurologic side effects. Trimethoprim, sulfamethoxazole, amoxicillin. These are antibiotics you may consider to use. But if a patient comes in and if the patient has suspected infection, an active disease, you should act preemptively. You should start antibiotic treatment without proof of underlying bacterial infection. I don't know. Is this here or is this here? Yeah. There. Okay, thank you. So this is just a patient, and that is interesting because I think we should keep that in mind. A patient come in with night sweats. Night sweats in myeloma are usually a sign of ongoing infection, either viral or bacterial. So you have to ask your patient, if the patient complains about weakness, tiredness, ask about night sweats. If night sweats are prevalent, if the patient reports about night sweats, think about considering an infection. And there's interesting data from one of the transplant studies. They looked at 104 patients and looking at the prevalence of CMV antibodies. There were 63% of the patients had CMV antibodies, and almost 50% of those had transient viremia after transplant, and a few of them had active disease where CMV disease was diagnosed. So if a patient shortly after transplant has a very slow recovery, has complaints of fatigue, weakness, and so on, muscle pain, think about reactivation of CMV infections. What are the drugs which are available? Of course, in patients on proteasome inhibitors, you use valacyclovir, which has been said to be more effective. The risk for zoster-associated neuropathy is lower with valacyclovir than with acyclovir. I'm not sure how solid this statement is, but these are the drugs which you use. Of course, in CMV, you have ganciclovir or valganciclovir. Influenza, of course, that's clear. And in respiratory syncytial virus infection, there's, of course, no prophylaxis. And if there's active disease, you can use ribavirin, but it is not very active in those patients. Now let's look at this lady, a patient with multiple myelomas, stage 3, cytogenetic risk. She had an infection, was started on thalidomide dexamethasone. She achieved complete remission. But with ongoing therapy, the patient complained of more and more problems when she was standing up, and she had increased orthostatic dysregulation and episodes of severe bradycardia, which are can be a consequence of thalidomide therapy. So thalidomide therapy can cause a lot of neurological side effects. Apart from painful neuropathy, you can experience bradycardia, arrhythmia, orthostatic hypotension, syncope, erectile dysfunction. So with ongoing disease and with cumulative dose of thalidomide, these problems become more and more prevalent. And, oops, I go back. So what can you do? Of course, in some patients where thalidomide is essential and no other drug is available, and where you have these arrhythmias, you can think about implantation of a pacemaker, or then you, of course, will think about the reduction of dose and treatment discontinuation. And if you have hypertension, you can use these drugs, but they are not very effective. Now, the same patient was then put on Bortezomib-dexamethasone, and she developed grade 2 polyneuropathy plus pain. So a patient on Bortezomib with polyneuropathy plus pain should be discontinued on treatment, so Bortezomib should be withheld in those patients. And the reason, and of course you should administer, and that is well known now, Bortezomib subcutaneously, because by using this route of administration, you reduce the peak levels, which you induce with the injection, by a factor of 10. So you have much lower peak levels, but the area under the curve is similar to the IV injection. That is well known now. And of course, with Bortezomib, you not only give it subcutaneously, but in those patients who are likely to develop PMP, with early signs of PMP, you certainly would consider to move from twice weekly to once weekly therapy. But something which is interesting is you should ask your patients, and patients should self-evaluate the degree of neuropathy they are experiencing. Why? Because when you rely on investigator assessment of polyneuropathy, this is from one of our studies, you see only very little grade 3 and 4 neuropathy. But when you ask the same patients undergoing this treatment, you see much more grade 3 and 4 neuropathies when patients assess the severity of neuropathy themselves. So you should ask your patients every time you see them regarding the presence of neuropathy when they are on Bortezomib treatment, and you see this discrepancy, and patients experience the severity in a very different way as compared to assessment by investigators. So investigators underestimate the burden of neuropathy in individual patients, usually. Those modifications, that is well known, grade 1 neuropathy, either go from twice weekly to once weekly. If you are already on once weekly, reduce the dose. Grade 2, same. If grade 2 plus pain, you have to discontinue. And you are aware that patients recover quite well from Bortezomib-induced polyneuropathy. I just have seen a patient of ours who had severe, what I call rapid onset polyneuropathy. He was not able to walk. He was in a wheelchair for a while, but he recovered completely, and now he's cycling through America from the west to the east coast. So you recover usually, or at least to a great extent, from Bortezomib-induced neuropathy, which is distinct to the Thalidomide-induced neuropathy, which usually is permanent or which only shows little improvement with further follow-up. Recommendations for Thalidomide: reduce the dose, grade 1, discontinue grade 2, and here you have to discontinue. If neuropathy is there is not much which we really can do. We have a series of different drugs. Usually patients are put on anticonvulsive agents like gabapentin, pregabalin. They are effective in a minority of patients. You can use different doses. You can use serotonin reactive reabsorption inhibitors like duloxetine. Other drugs, sometimes you need to go to morphines, but all these treatments are suboptimal at best. Now let's briefly touch on thromboembolic complications, which are associated with several risk factors. The incidence There are treatment-related risk factors, patient-related risk factors. Treatment-related risk factors are, of course, very important. It's IMiDs, dexamethasone, and other drugs. And the prevalence, which has been reported and which is seen in the clinic, varies quite widely between 5 and 30%, depending on the patients and depending on the treatment the patients are receiving. So the question is, which prophylaxis should be done? And there are 2 studies from Antonio Palombo's group. He looked at patients randomized, at patients on lenalidomide low-dose dex therapy. He randomized them to aspirin or low molecular weight heparin. And when he did this study, the outcome was very interesting because there was not a big difference in the risk of occurrence of thromboembolic complications. It was slightly lower with low molecular weight heparin in this study as compared to aspirin. And you see here the absolute difference is quite low. In a sense, the incidence here is quite low, but what this slide shows you that you can use both aspirin and low molecular weight heparin, but there are algorithms you may follow. And for instance, if you have a patient who has only patient-related risk factors and is treated with IMiDs, then the recommendation is just use aspirin. And if the patient has a treatment-related risk factor or 2 other risk factors, the recommendation is to use low molecular weight heparin or full-dose warfarin. So aspirin is probably the way to go in many of your patients. If you have a very high-risk patient, you may use low molecular weight heparins. Some people still use warfarin. But still, all these recommendations have some, let's say, limitations because there is not much data available on randomized trials. So the optimal duration is not defined of prophylaxis. Usually you treat until complete remission and then you stop. In case of occurrence of VTE, discontinue the treatment with IMiDs and then augment the antithrombotic prophylaxis and then resume IMiDs when full anticoagulation is established. And of course, you know the adverse events, which are quite rare, of the adverse events of thromboprophylaxis, which is bleeding, which is quite rarely seen. And sometimes people ask whether the new anticoagulants are of value in myeloma. Probably they are of value, but they are not approved for treatment in multiple myeloma as yet, but some people use them. Rash can be life-threatening. Very rarely when patients develop Stevens-Johnson syndrome during treatment with IMiDs, thalidomide, lenalidomide, pomalidomide, usually the rash is mild. So if rash occurs, you just use topic therapy like steroids. You may use antihistamines. And if the rash is severe, then you have to discontinue therapy. If it's very severe, you have to use high-dose oral steroids. But then the question pops up. You have a patient who has had everything with the exception of IMiDs. You put him on an IMiD, and the patient develops rash. And the rash is severe, so can you continue treatment in those patients or not? And there's an interesting study which tells you that, or tells us that we can desensitize patients with rash by starting with very low dose lenalidomide, as shown here, with long treatment intervals, and by slowly increasing the dose of lenalidomide and by shortening the intervals, and those patients were then able to tolerate lenalidomide. So you desensitize patients against lenalidomide if there is absolute need for them to be treated, for instance, with lenalidomide, and if lenalidomide induced significant rash. Diarrhea. Diarrhea can be very debilitating particularly after long-standing lenalidomide therapy. Patients tell you it's a problem in the morning. They are on lenalidomide for, let's say, for 2 years and so, and the diarrhea worsens during this time, and they are telling you, I can't leave my home in the morning because I can't control my stool. So in those cases, you should consider something which is specific to immunotherapy, to lenalidomide, namely bile salt malabsorption syndrome, which is induced by lenalidomide. So bile salts are not reabsorbed properly, and this causes diarrhea. And I mention this because you can use, apart from the standard treatment, in those cases, a specific drug which is called colesevelam. It is a bile acid binder, and this drug will provide relief to most of your patients with this syndrome. So if you have a patient on lenalidomide with severe diarrhea and everything has been exploited, conventional therapy, try to give the patient a treatment with colesevelam. You will be surprised how many patients respond in very short time, within 1 to 2 days. And then if that works, then you can use this treatment for long. So with that saying, yeah, and that is a study which just shows the efficacy of this treatment in patients with bile acid malabsorption syndrome during lenalidomide. You reduce the stool frequency. You significantly change the well-being of your patients. So you have something in your hand which really makes a difference within a few days. So just to sum up here, of course, supportive treatment is an essential element in treating myeloma. It not only improves the quality of life of your patient, it not only reduces the need for hospitalization, but it also increases the survival. It reduces mortality, which is of very, of course, eminent importance. So with these measures, you can, particularly when it comes to infections, you can reduce mortality and improve survival in your patients. So I need to rush and move on to maintenance therapy, just very briefly. With maintenance therapy, we want to increase the progression-free survival, but we not only want to increase progression-free survival, we also want to improve overall survival. And by maintenance therapy, we want to not only prolong survival, progression-free survival, we want to deepen the response, myeloma response. And these are the 6 trials which have been conducted with thalidomide maintenance therapy after high-dose therapy, after transplantation. And when you look at the response rate, you see that you can improve responses even with thalidomide. You see here, initially very high doses were used. Low-cost used a very low dose, 50 milligram. And when you look at the next slide, then you see a meta-analysis which recently has been published looking at progression-free survival. And you see here that low-cost with low-dose thalidomide 50 milligram did quite well when it comes to progression-free survival. But with thalidomide maintenance, you also improve overall survival. The hazard ratio is 0.8. It's not a big improvement, but it's a significant improvement. And here you see the low-cost trial with 50 milligrams. Probably 50 milligrams is not enough. Probably you should go, if you plan for maintenance, you should go with 100 milligrams one daily. So that works in young patients. In elderly patients, you have to be more careful. This is data from Garrett Morgan with thalidomide maintenance, progression-free survival in elderly patients. Significant improvement in PFS, no improvement, large patient number in progression in overall survival. And there was a very important message, which I think we should take it notice, and that is this notice here. When you look at overall survival in standard risk patients, you don't see a difference with thalidomide maintenance or without. But when you look at those patients with high-risk cytogenetics, you see that patients with high-risk cytogenetics do much poorer with thalidomide maintenance. So if you consider maintenance therapy with thalidomide in elderly patients, exclude patients with high-risk cytogenetics because they won't benefit. So just to cut this story short, increase in overall survival in patients after transplant, negative effect in patients with high-risk cytogenetics, particularly in elderly patients. Optimal dose is not known, probably 100 milligram. Optimal duration, probably 1 year is enough. Benefit independent of response status. So I would go with 100 milligram, but I accept that thalidomide maintenance is nowadays not very frequently used. Now we have a new type of maintenance therapy, which you are well aware of, which is lenalidomide. And you're well aware that there are two big studies, in a sense 3 studies, which looked at the value of lenalidomide maintenance after transplant. This is the American study, the US study, showing a significant improvement in progression-free and in overall survival in patients after transplant. Lenalidomide continuously until progression after transplant improved survival in this study. There's a French study which did not confirm the improvement in overall survival, it confirmed the improvement in progression-free survival, and there's an Italian study which confirmed both data here. So what is the best to do? You do a meta-analysis. You combine data from the American study, from the French study, and from the Italian study, and you do a meta-analysis. And the meta-analysis was based on individual data, so they had the access to all individual patients to their data. So what did they do? What you see here is the forest plot. The French, that is already overall survival. So you have here the American, the French, and the Italian study. When you pull this data, you get a significant improvement in overall survival by using LEN maintenance therapy. So LEN maintenance therapy improves overall survival, but you have to look again at the specifics of your individual patient. So here you have these survival curves. So the difference in overall survival at 7 years is probably 26%. You have at 7 years follow-up a difference in survival of 26% by lenalidomide maintenance therapy. And if you calculate it differently, if you look at the average gain in survival, the average gain in survival is about 2.5 years. 2.5 years. So that is significant, of course. But you have to look at the details again. And you see here the forest plot, but you see here 2 curves where you have to be careful. So patients with stage 3 and patients with high-risk cytogenetics did not benefit from lenalidomide maintenance therapy after transplant. So if you consider lenalidomide maintenance therapy, it's not approved in a patient. Exclude probably patients with stage 3 and exclude certainly patients with high-risk cytogenetics because it won't pay off. And you have to acknowledge that lenalidomide maintenance without any melphalan increases the risk for secondary primary malignancies. It's a moderate increase. This is the control arm here, and this is the lenalidomide treated arms. A moderate increase in secondary primary malignancies, but the benefit, of course, outweighs the risk here. I think, yes. So the question is, why is lenalidomide so active? Of course, we don't have a good answer. I don't have the right answer. but we can discuss. But when you look at patients on lenalidomide maintenance therapy, these are those patients here, or here those patients. These are patients who receive lenalidomide for induction therapy. These are controls. And when you look, for instance, at different cytokines, you see that lenalidomide maintenance increases the expression of several cytokines, like interferon gamma, like TNF, like IL-21. And here you have the increase of interferon gamma again, of IL-4 and IL-17 in patients on maintenance therapy, as compared to those on active induction therapy, as compared to controls. So lenalidomide has, when you give it for long, an immunostimulatory effect that is nicely shown, and that is also shown by the Spanish group, by Pavia. So you increase the CD4 cells, CD8 cells, NK cells here by lenalidomide maintenance therapy, and the increases with duration of therapy. And you see here again the increase in regulatory T cells with lenalidomide maintenance therapy, and it increases with duration of therapy. So lenalidomide is an excellent drug for good risk patients for maintenance therapy. What shall we recommend? High-risk patients with poor cytogenetics. There is only one study which is interesting to be discussed. This is the Holland study comparing VAD with BED, that is bortezomib. And those patients went to thalidomide maintenance, and those patients received bortezomib, adriamycin dex, and then bortezomib maintenance for 2 years, every 2 weeks, one shot of bortezomib for 2 years. And they received thalidomide. The outcome is shown here. It's not a complete or fair comparison of both drugs regarding their impact on maintenance, because the induction therapy was different. But still, it shows the authors did different analysis, landmark analysis, and by doing this landmark analysis, they were able to show an impact of bortezomib maintenance therapy over thalidomide maintenance therapy in terms of improving survival. And what you see here, when you look at those patients in general, you see here, these are the patients, this is progression-free survival. These are patients with bortezomib adriamycin, with normal cytogenetics. These are patients, normal cytogenetics with VAD. And when you look at those with deletion 17, you see they do much better when they are treated with bortezomib as compared to VAD and thalidomide. And the same is true for overall survival. You see here, bortezomib is able to neutralize, at least in part, the negative impact of deletion 17p in these patients when they are treated with thalidomide. But we should consider thalidomide may even have reduced negatively, may have impacted on outcome in those patients as well. But nevertheless, bortezomib would be an option for high-risk patients with after transplant. So coming to a conclusion, lenalidomide maintenance after transplant improves OS and PFS. It increases slightly the risk for secondary primary malignancies. It is not an excellent drug, good drug in patients with high-risk cytogenetics in stage 3. Bortezomib maintenance is superior to maintenance with thalidomide in TEL-17 patients. And there is, of course, no increase in secondary primary malignancies with bortezomib, of course. But I have to mention that none of the maintenance therapy which I discussed are approved in the US and in Europe as well. And with that saying, I would like to thank you for listening so long to me. Thank you for your attention, and greetings from Vienna. Thank you very much.